So the American Psychiatric Association says that for you to practice and use this book, there are some specific things that you need to know. And that the DSM-5TR has new scientific evidence that's included in it. It clarifies the diagnosis criteria and has some changes to the criteria. And they're improving on it all the time. So this is the reason why they went from the DSM-5 to the DSM-TR. They wanted to clarify some things. They wanted to add some mental health diagnosis, take some things away, and then they wanted to focus more in on mental health disorders and rather than on improving their criteria set. So they felt like the upgrade was needed. And so we're using the ICD-10 CM codes, but then we will be looking at going to a higher level, the ICD-11 soon. But this is 10 years worth of research that we're talking about here. It's not letting me advance. Okay, there it is. So March 22, the APA released the DSM-5 TR, the DSM-5. And then, no, March 3rd, I'm sorry, tongue-tied. The DSM-5 was released in 2013. And it is used as the official diagnostic guide across the United States now. Nobody's using anything else. Even your insurance companies are using the DSM or DSM-5TR. The TR was introduced in 22. And then one thing to note is that the federal government is also using the DSM-5TR for all diagnostic criteria. And there are some other manuals that were used, like, well, the ICD-10, so the International Classification of Diseases, is the most well-known and the most popular because it lines up with the DSM. And so the United States, what we did was we turned around and we made our DSM mirror what the ICD codes were, because ICD codes are being used for insurance purposes already. So we wanted to be in line with that. There's also a psychodynamic diagnostic manual and a hierarchical taxonomy psychology manual, but those things are not being used at this point. But they can be used as references in your practice. Okay, so the DSM is organized in a very specific manner. The primary goal for the manual framework are to help clinicians make accurate and consistent diagnosis across all planes and to help researchers better understand disorders related. So the sequence is recognition of the advancements and understanding of all the things that are going on and encouraging research. This is what APA is saying. But then it's also showing the clinician and presenting the how things are grouped together based on your developmental span. So from cradle to grave. And they're showing disorders that are typically diagnosed during childhood first, and then they're showing you things that are, or diagnoses that can be diagnosed later on in life. So we have 22 disorder chapters, and we have 70 total disorder names. It's very extensive. And this is what we're looking at here. These are the 20 diagnosis orders and categories that we're going to be looking at. If I showed you the book is very, very thick and very intense. It is divided into 3 sections: the basic information, the diagnostic criteria and codes, and the emerging measures model. Okay, I'm going to stop here and I'm going to put a lot of emphasis on culture because the book puts a lot of emphasis on culture. The terms racial, there are a lot of terms that they've taken out of the DSM to be sensitive to racial, ethnic groups, and to highlight social constructs that are natural to your race. They are using the word ethno-racial. Is used to denote that things such as Hispanic, white, African American, they're lumping it all together. And then they took out the term minority and non-white or avoided because they wanted to describe social groups in relation to racial majority. So you'll be looking at this book as if they've taken out a lot of things that they thought were offensive to racial groups. So they don't use the word Caucasian at all. They're using the word Latinx or Latina or Latino to denote whether your client is male or female. But they've taken out a lot of things that describe racial groups or that would offend racial groups at this time. So they're taking attention to making sure that we have a good understanding of our clients. So in addition, information is provided on variations in symptoms and expression, attributes, or disorders for the cause, and culture norms that may affect the level of perceived pathology that are reported. And attention was paid to the risk of misdiagnosis when evaluating individuals from socially oppressed ethno-racial groups. So they paid a lot of attention to making sure that when we're making diagnosis, that we're not misdiagnosing our clients based on their culture or their race or their ethnic group. They found that there were a lot of misdiagnoses that were going on and reports that were happening to boards based on the fact that people felt like they were being targeted based on their race or their ethnicity. So they went back to the drawing board with the DSM and really paid attention to the different diagnoses that were there and how they may affect somebody's culture or race. So they really paid attention to these things. And you will find that throughout the book. Okay, so section 1 introduces a history of the history, organization, reporting, regrouping of the disorders, and it's beginning to be in line with the ICD-10, and they tell you, to ICD-10, but also the 11, and they tell you why, because we're moving toward the ICD-11, which some countries are already using, but is not being used here in the United States yet. They give you a clear definition of what mental health is, and culture along the lines of sex and gender differences. And that's another thing that you will find in the DSM now. They talk a lot about, not only I've been saying the word culture, but they're also talking about sex and gender differences. And they're being very careful to make sure that you understand as the clinician that things that are attributed to someone's sex, their gender, their race, their ethnicity are things that we need to be cautious of and make sure that we are being very hyper aware of when we're making our diagnosis. It covers how medical professionals should use the book, and it includes a lot of guidance when mental health concerns involve the legal system and the court system. Sorry about that. All right, so DSM additions and revisions can be considered. This DSM, some people consider it as 2 books in one because it contains both the diagnostic criteria and ICD-10 codes for mental health disorders and is a written resource about each mental health disorder. And it covers diagnostic features, prevalence, development, the course of the questionable diagnosis, And risk factors, it talks about sex and gender, the related culture related to diagnostic issues that are associated with suicide, differential diagnosis, and comorbidity. You can see this as that. Remember, I was telling you about the ICD, which was another manual that was considered for use in diagnosing mental health conditions. Well, it is what the US did with the DSM was they took the ICD-10 codes and they placed them right next to your diagnosis. So you'd be using that if you are a private clinician and have your own practice, where you're entering billing, the ICD-10 is what you're going to be using for billing along with CPT codes, but I'll talk about that later. And so, yeah, it is 2 books in one. It talks about culture. This book goes in depth about telling you how and why different diagnoses should be made. It's a pretty, I would say it's very in depth about what needs to be happening when you're making diagnosis for your clients. So what they're saying is the DSM with the additions and the revisions is that it reports the scientific knowledge that was accumulated over the 10 years, and it adds additional information. I think I've already talked to you about that, but it adds additional information, and it makes an intentional and inclusive language change, culture, and psychiatric diagnosis. So I put this here because I wanted to make sure that you understand that this book talks a lot about culture, and it covers culture, it covers sexual orientation and gender, acknowledgement, and for psychiatric disorders. All right, so I'm gonna spend a little time here because coding is important, especially if you work for yourself. There was a time when coding for mental health disorders was specific by the geographical region and the country. The DSM-5 brought about the unification of mental health coding across the world. So basically, everybody was doing what they wanted to do, but they were trying to line up their coding for billing. So it's a numbers game, it's a money game. So in order to bill insurance, you have to have a code that goes along with it. We were using the DSM-4, which was aligned per se with ICD-10 code. So basically, you would have to find a code that was correlated to what your diagnosis was. And what the DSM-5 did was they put them right together and they correlated them specifically instead of you having to find them separately. So in October of 2015, the official coding for the United States was introduced, the International Classification of Diseases, 10th edition, which is the ICD-10. Each country member of the World Health Organization is required to use the same codes, but may change the disorder names and diagnostic criteria that is based on the country's health approach and culture. So the United States and the National Center for Health Statistics manages and provides the permissible ICD-10 codes for mental health disorders. And the codes that appear in the DSM are the ICD-10 codes that are equivalent to the DSM diagnosis. So you don't have to find it anymore. It's right there with you. Each code corresponds to a billable diagnosis for insurance purposes. So be aware that the World Health Organization released the ICD-10-11 in January 2022. And there are over 30 nations that are already using it. The United States, the US government, it's proposed that we'll go to the ICD-11 in 2025. But they're giving us time to make the switch. There's some countries, they just switch it and you just have to use it. Clinicians just have to figure it out. There is a learning curve. The United States we're trying to gradually move people over to the 11. I've read some peer review that says it may come later in the year, but most definitely will be moving there in 2025. And we may see a revision of the DSM-5 because the ICD-11 has moved and has different codes in it. So then that would mean that they would have to either push out a revision, or they would have an addendum, or they would actually have to change it altogether. So we'll see. Okay, so the ICD-10 has over 70,000 different codes that describe diseases, signs, symptoms, abnormal findings, complaints. So if you go to the doctor, you know that I want to call it a triplicate form that you receive from your doctor's office. Mine is white on the top, and then it has a yellow copy, and then it has a pink copy. If you look at that, that has a good majority of some of the codes that are used specifically for like primary care. Now, we don't have a triplicate form. I tried to look for one because I thought it would be interesting just to find and show you, but we don't necessarily have one. However, the DSM would be our triplicate form. But it's organized into G codes, Z codes, and F codes. Okay, so the G codes talk about diseases of the neurological system. So that would be something like Alzheimer's disease. That is included in our DSM because the Alzheimer's disease and other neurological diseases have effects on mental health. And there are specific mental health components, especially to Alzheimer's, because there is there's a change to the brain. A change to the brain means there will be some psychological mental health implications for that. The Z codes describe situations where the client doesn't have a specific disorder, but services are required anyway. Such as if a client has a personal history of psychological trauma, or an authority body has requested a general psychiatric evaluation. So that would be a Z code. That would be if they were court mandated. So you can use that code to prompt insurance that way, or to, this is the way that it's kind of like a bold and then italicized, kind of like how it is here. The codes will be like that for insurance companies. The F codes make up the majority of the mental health ICD-10 codes. Okay, so section 2 talks about diagnosis criteria and the codes. This section is the largest section of the book, and each chapter covers a type of condition or specific condition defined and explained within it. It's very extensive. Let's go. Okay, so I will talk about the things that have changed in the DSM, or things that were highlighted for specifically the TR. Prolonged grief disorder was added to the TR, and it's a new mental health disorder that was added. It talks about trauma and stressors. Prolonged grief disorder is a maladaptive grief reaction that's present for adults for at least 12 months. Pay attention to the time frame here. This is why it was added, but pay attention to the time frame for diagnosis, for diagnostic purposes. 12 months for an adult and 6 months for a child after the death of someone for that bereaved person. So this is someone who has had a very long time and a long process with processing grief. Like I said, pay attention to the time frames. For adults, that's 12 months. For children, it's 6 months. And they're looking at the age and stage of, the client as a whole. The key symptoms experienced are for criteria A is experiencing daily a disabling degree, an intense yearning, longing for the deceased, preoccupied with thoughts or memories of the deceased. For children and adolescents, and sometimes there's a preoccupation that may be focused on how that person died. The symptoms associated with prolonged grief disorder have some overlapping with major depressive disorder and PTSD. So you have to be careful about differential diagnosis. And what you're going to be careful about for your workflow is you're looking at the timing and the intensity and the age and stage or the person in general. Both of these symptoms that overlap with prolonged grief disorder, but differ by lacking intensity, yearning, and preoccupation with the deceased person.
We have a question or a comment, Dr. Brown, from Ms. Clark, who says, it's interesting that it's longer for adults since they have mastered more coping skills than children. Is that because children are viewed as more resilient than adults?
No, it's because children are considered in some ways to be more maladaptive than adults. They don't have the coping skills necessary. They haven't learned them. They haven't mastered the coping skills necessary to deal with grief just yet. So you would not expect a child, you wouldn't wait that long to intervene for a child, but you would provide space enough for an adult, if that makes sense. So that's why you're looking at 12 months instead of 6 for an adult as opposed to a child. Is there another question?
No, that was it. Thank you so much.
Okay. There are several other DSM mental health diagnoses that were developed after stressor of a death, such as uncomplicated bereavement, which is considered a normal reaction to loss of a loved one with symptoms that are similar to depression. But listen, what we're looking at is the onset. The onset would be the death of a loved one, and then you're looking at the duration and your time. That's going to help you with differential diagnosis. And that's going to be the key to making sure that you give the best picture of what your client is going through at the time that they present to you. Then there's also an adjustment disorder. It's a limited time maladaptive response that occurs within 3 months of the stressor. So if we're talking about bereavement, you have the bereavement, which provides the onset, 3 months from that, or 3 months in total, and you come in somewhere in the 3.5 month. You can use adjustment disorder because we're looking at time and duration. You would not use prolonged grief disorder because you're looking at time and duration. So if they've only had the loved one that was passed away for 3.5 months, 4 months, you would use adjustment disorder, or you could use uncomplicated grief disorder, but you would not use prolonged grief disorder until you're looking at an adult that's a year out or a child that's 6 months out. Does that make sense? Make sense? Okay. So this would be how you would look at differential diagnosis for that adult as opposed to a child. So remember when I was telling you that the DSM now looks at showing the clinician what diagnosis can be used for childhood, and then they move to adulthood. This is an example of how that works. And they put it all there at the same time. So you could use differential diagnosis there in the DSM. But they also talk about culture. So you will look at the cultural differences for your presenting client.
I have a question, which is, what about the severity when looking at children that may have witnessed a suicide or traumatic event?
Yes, you are right. That means that you would also look at, that's differential diagnosing. You may want to look at adjustment disorder, or you may want to look at post-traumatic stress. But the difference in differential diagnosing is you're looking at time and duration. So you're looking at onset, time, and duration. So what was the preceding factor, or precipitating factor, or what in layman's terms, the straw that broke the camel's back? And then what happens after that, duration and time, is what you're looking for when you're making your diagnosis. But you also have to consider differential, meaning other diagnosis, which would be depression, anxiety, uncomplicated grief, the prolonged disorder. That's kind of where you would go in. You would be kind of computing and trying to pull in what you would feel would be the best. So a child that witnesses a death, yes. Then we're looking at, like I said, we're looking at the onset and duration and time at that point to make a differential diagnosis. Okay, so there are other conditions of clinical attention that they put here. I thought, which was interesting, was internet gaming disorder. That showed up in the DSM-TR. There's a whole genre of people that are gaming. And so there are people that are addicted to gaming. Addicted is connected to us because we deal with clients that have addictions. And so internet gaming disorder was something that was very interesting to me. Another thing that was interesting to me was neurobehavioral disorder associated with prenatal alcohol exposure. I know that's like a mouthful, right? My question is to anybody, when I say that, or when you look at that, the last bullet there, what diagnosis do you think about that you already know, like that you already know? Because what they did was they went in and they renamed a lot of these disorders so that they would be politically correct and not offensive to others.
Fetal alcohol syndrome seems to be what the group feels is that's a restatement of. And then one person had asked, and I forgot to ask you, to restate the amount of time required before you make the diagnosis of prolonged grief disorder.
Sure, no problem. Okay. There it is right there. Prolonged grief disorder. You are looking at criteria A, that the person is, the situation is debilitating to the person. The criteria is 12 months for an adult, 6 months for a child.
12 months.
Yes, 12 months for an adult, 6 months for a child. And then the differential diagnosis that you may want to consider would be uncomplicated bereavement, adjustment disorder, major depressive disorder, or an anxiety disorder, or probably even post-traumatic stress, depending on what the situation was, but behind the onset. Does that make sense?
It does. I have another question for Ms. Clark. What's offensive about fetal alcohol syndrome? Just curious.
Not sure. I cannot answer that question. But I will tell you that there are a lot of renamings that happened in the book. I don't know what was offensive about fetal alcohol syndrome, but now they're calling it neurobehavioral disorder. Sounds like what they're trying to do is describe what happens to the patient instead of describing the patient, if that makes sense. So fetal alcohol syndrome does affect the neurobehavioral components of a child when they're born. It changes their behavior because they were exposed to alcohol in utero. So they're describing it instead of describing the patient.
Right. So yeah, they're moving away from labeling the individual into labeling the behavior or the disease.
Labeling behavior. Mm-hmm. Yeah. So they have a section called conditions of clinical attention. And I want to bring attention to suicidal behaviors, because sometimes when we are making diagnosis, even in the clinical setting, sometimes it's hard for us to make those diagnoses and put them on the form, so to speak, because we were not able to describe what was going on. We could only put a label there. Now, with the DSM-TR, we're able to describe what's going on to the insurance company to make sure that they understand what's happening. So suicidal behaviors and non-suicidal self-injury are conditions of clinical attention with the ICD-10 code, each to indicate if the client is currently engaged in suicidal behavior or non-self-injurious behavior, or has a history of behavior. These additions, part of the symptom in many diagnosis categories will help you document the suicidal or non-suicidal self-injurious behaviors of a client. And the mental disorder is not also required to list either condition. So I know that's like a mouthful, but what did she really just say? Basically, what I just said was, we are describing what's happening to the client right now. On initial encounter, the client is suicidal. Yes or no? This is what you're going to be able to answer now. You used to just have to say the client is suicidal, and you had to explain what was going on, and they had to read it. Now, what you're doing is putting a bold there and saying, when I saw this client today, they were not suicidal. When I saw this client today, they were thinking about self-injurious behaviors, but they were non-lethal. This is what I mean. You have clients, when you ask clients, are you suicidal? Because you ask the question, you don't dance around it. They say, sort of. And you're like, what is sort of? Well, this is what the sort of is. Well, I actually like sitting in hot water and I punish myself. Well, that is a self-injurious behavior. It is. But is it a suicidal behavior? No, it is not. Will it hurt the client? Yes, it will. Sitting in scalding hot water will hurt the client. They may get first-degree burns, second-degree burns. They may get burned. But will it cause that client to die in the current moment? Possibly not. I said possibly because you just never know. But is it a suicidal behavior? No. Is the client talking about hanging themselves, walking out in front of a bus, shooting themselves? Yes, that is a 91A. That is a suicidal behavior on initial contact. If the client is talking about, no, I just want to sit in this hot water, I'm going to cut my wrist, I'm going to roll my ankle or do something to harm myself, but it does not equate to that person being suicidal, that's what we're looking at. Okay. The 91D, suicidal behavior subsequent encounter, the client has previously received treatment while having suicidal behaviors and now is presenting to you in the clinic. So that's somebody who had an attempt or had some behaviors, but they are not presenting to you like that now. 51 is a history of suicidal behavior that has occurred during the client's lifetime. And note that this is a lifetime diagnosis that remains permanently listed. The 51 is a history that you have a history of the behavior, no matter what that behavior is. Okay, so then you have the non-suicidal self-injurious behaviors. Let me go back here. Suicidal behaviors, you have a plan. You're going to shoot yourself. You're going to hang yourself. You're going to step out in front of a car. This is what this looks at. And then the 91A talks about what they present for right now when they're in the clinic with you today. The 91D talks about the behaviors and that have occurred in the past. The 51 talks about the whole entire history of the client over their lifetime. Okay, so the non-suicidal self-injuries is just what I was talking about before. You want to roll your ankle. You're going to sit in hot water. You're going to withhold food from yourself. Same situation with the previous slide. The 88 talks about current self-injurious behaviors. This is what we didn't have any wiggle room in the first, in the DSM-5 to explain what was going on with the client. You either said they were suicidal or they're not. But now you can say whether they have a plan to harm themselves or whether they have non-suicidal self-injuries. Like I said, pulling out the hair, something like a stigmata where they punish themselves, you would use that here. Or is a differential would be some type of anxiety disorder. But the 52 is a history of non-suicidal self-injury. That is a lifetime diagnosis that stays with the client. But the 88 talks about self-injurious behaviors without any suicidal ideations that are connected to it or attempts that are connected to it. Okay, so it says what's in a name for a good reason. Remember we were talking about fetal alcohol syndrome, which they're now calling neurobehavioral disorder associated with prenatal alcohol exposure. That's a mouthful, but they are renaming a lot of the diagnosis here. So the APA approved name changes for two disorders. Functional neurological symptom disorder used to be somatic disorder or any related. Conversion disorder. Now you're going to call it functional neurological symptom disorder. I'm sorry, I'm kind of chuckling a little bit here because I'm like, well, that's a mouthful. A lot of these are a mouthful. And then you have intellectual developmental disorder. It's replacing intellectual disability, or what people used to call being, what layman's terms, people being called being mentally retarded. Yeah. They have changed the name again to intellectual developmental disorder. I want to make sure that you understand that when you go to the court system, they are not using these same terms. Court systems are still using the terms from the DSM-4, or mentally retarded is still a part of the legal system. So when you're saying intellectual developmental disorder, they probably don't know what you're talking about. They're still using mentally retarded in the court systems. They're slowly coming to our side of thinking. But right now, don't be offended if that's what you see or that's what you hear in the court system. That's what they're using. Functional neurological symptom disorder requires one or more symptoms of altered voluntary motor or sensory functioning, incapable with known neurobiological or medical conditions. So this would be something like a loss of hearing with no damage to the nerve, blood circulation, and ear structure. Why would we be thinking about this as clinicians? Well, because it is directly connected to our clients' mental health, because somatic means body, and we're talking about what's going on with their body. And of course, I talked about intellectual developmental disorder, which is, like I said, don't be shocked if you hear mental retarded when you go to the court systems, because they're still using mentally retarded.
Yeah, we have some comments that people sort of cringing at even the mention of that terminology, and stating how, things have just changed in terms of how we view and discuss these things.
Oh yeah, most definitely. There are words that we don't use anymore. And I stopped because I was thinking, okay, I wanted to say these are the terms that laymen would say, these people are mentally slow, or, they have an IEP or something of that nature. But yeah, they do make you cringe when you have to hear them in a different light. There are revised criteria that were altered for autism spectrum disorder, the substance and medication-induced bipolars, major depressive disorders, and avoidant restrictive foods. The criteria A for autism is revised to clearly require that all three types of deficits be presented, stated, or manifested by all of the following. I'm reading this directly from the book. These deficits are deficits in social emotional reciprocity, deficits in nonverbal communication and use of social interactions, and deficits in developing and maintaining and understanding relationships. That the criteria says you must meet all three now. You can't have one. I want you to look at the DSM talk. When they have time frames, look at it, because that's sometimes what people get dinged on when the insurance comes back and they kick it back because the time frames aren't correct. So or the timeframes aren't correct, or that person didn't meet all the criteria. That'd be reason for, Blue Cross Blue Shield coming back and going, hey girl, or hey guy, we need run us our money back because this person does not meet that criteria. And for example, with autism spectrum, they must meet all 3 of the criteria. Substance medication induced bipolar, criteria B addresses when the criteria A symptoms must develop. So again, we're looking at time frame. It now includes after exposure or withdrawal from a medication. So you can't say this person is bipolar and they took this medicine and this is kind of the medicine was the onset, but then you use the diagnosis of that person being bipolar 1 or 2. No, you cannot do that. You must use substance medication induced bipolar or related disorders. The differential diagnosis would be bipolar 1 or 2, but you must have and consider the medication would be the onset, which would be the description of why that person is behaving as if they're bipolar. I think that makes sense. So you must use that. You can't say this person took Seroquel and then they were bipolar and now their diagnosis is bipolar 1. No, you have to go back because we're looking at onset. Onset is the introduction of the medication. We would look at bipolar 1 or bipolar 2 if there was no medication that was in the onset. Or as I've talked about, the straw that broke the camel's back. Major depressive disorder, the occurrence of the major depressive episode, the current presenting episode is not better explained by another mental health disorder like schizophrenia. You have to look at criteria D now to make sure at least one major depressive episode is not better explained by another mental health. So basically, before you're making a major depressive disorder diagnosis, you have to make sure you're looking at time, duration, and differentials at this time. For avoidant restrictive food, we are looking at no longer requiring that eating or feeding disturbances be manifested or persistent failure to meet appropriate nutrients. So basically what they're saying is, if you're looking at someone that has, they're restricting or avoiding food, again, we're looking at time, duration, and criteria. They have to meet all of the criteria for you to be able to use avoidant restricted food disorder. Because you also have to look at something, avoidant restricted food disorder, nobody picked it up. You would be looking at, this is where they're lumping in anorexia and bulimia. This is where they're lumping that in it. So instead of calling it anorexia or bulimia, they're calling it avoidant restrictive food disorder. And
I'm sorry, Ms. Clark was pointing out that when she worked in a psychiatric hospital, insurance companies didn't like to pay for substance-induced mood disorder.
No, they want to, they're more likely, that's kind of weird because you said you're working in substance abuse. So you're saying, hey, this person had a psychotic break when they took this. I had a client like that was microdosing herself with THC, and it caused an onset of a mental health issue. And the onset was because she was microdosing. There are some people, hey, I know Snoop Dogg says that weed makes him mellow, but there are some people weed makes very psychotic because it just does not align with their brain chemistry, with their body chemistry. Once that substance gets in their body, it's, all out war for their body. So for some people, it may make them mellow, but make sure you're asking your clients about that. Because if they're microdosing with THC or they're microdosing with weed or they're using brownies, or if they're microdosing with any other substance, Percocets, anything like that, all those medications, although for the most part, they are very safe or safe enough. And I say that safe enough because FDA approval for our consumption. Some of those medications cause psychiatric mental health issues for our clients. And that is the onset of the mental health break. And you have to describe that when you're using DSM and for billing purposes. So she is correct that there's some insurance companies that do not want to pay for some of these things. They really want to see that maybe it was nature and nurture beside and not a chemical.
And Miss Cox, excuse me, is asking, just to clarify, autism spectrum disorder must meet all diagnostic criteria A to E. A must have all three.
Okay. That's a complicated question, but the answer is yes and no. And this is what I mean. Autism spectrum disorder has several different criteria, A, B, C, D, E. And in criteria A, they say you must meet all three of criteria A. You must meet 2 criteria in B, 3 criteria in C. So you have to look at the time durations in each criteria for autism spectrum disorder. And for criteria A, you must meet them all before you can proceed to B or proceed to D. So you have to start at the top, make sure that person meets all those criteria, then you can proceed and move down. She okay with that? Okay. So they added and removed diagnostic specifiers for like bipolar 1 and bipolar 2, severity specifiers and ICD-10 codes. For a current manic episode, they're allowing you to make some provisions and be specific about what you're seeing at the time the client is presenting to you. Specifiers and associated ICD-10 codes, they follow their criteria to the T. So when you're making these diagnoses, make sure that your client meets all the specifiers and criteria. They also have a criteria for gender dysphoria. And I told you that they were looking at culture and they're paying attention to sex and gender now. So gender dysphoria is there, but that person must meet all the criteria before you can give that diagnosis. So it's still, you must start it here, start at the top and go to the bottom to make those diagnoses. But the terminology is more specific for gender dysphoria. And it's to use a more culturally sensitive and less stigmatizing language. So like I said, they're moving away from offending people and trying to be as neutral as possible. All right, let's talk about workflow. Workflow is you want to get a good psychological assessment. You want to do a mental health status exam or a mental status exam. And then you want to develop your diagnosis from there. So you want to complete a thorough overview of what you see is happening to the client. Then you want to describe what's going on. So we're describing who, what, when, why, where. We're describing the presenting problem. Why are they here now? The list is their complaints, and the duration of time and symptoms. That's exactly like, pay attention to that duration of time and symptoms. And then if they had any previous treatment, what do their medications look like? What do their medical histories look like? Any previous treatment that's encompassed through hospitalizations and psychiatric conditions. I always ask somebody, do you have a social worker, a psychiatrist, a psychologist, or a counselor? That will open the door and the segue to, yes, I had a counselor. Yes, I went to Crossbridge. Okay, well, then that gives you some of your duration of time, how long they may have been there. Then that means that person has a good knowledge of whether or not they have a DSM diagnosis, what medications they're taking. So you can have a very thorough discussion with people like that. You can also ask them about childhood involvement with therapy or substance abuse and treatment. You want to get a good picture of who we're looking at. So also in workflow, we're looking for a family history. Some people do a genogram. Some people just write it down. They make their own, flow chart. You want to look at the psychological stressors in their micro, meso, and macro environment. So you want to know what's going on in your home, what's going on in your community, and then how is that affecting what's going on in our collective globally? How is that affecting you? So micro is in the home, meso is in their school, macro would be the school system. How are they matriculating? How are they doing? If it's not working for them and one thing's blacked up, it all flows downhill. You want to look at educational history, their social functioning. Always ask about those things. Sometimes it's forgotten about. what does their peer groups look like? What are their networks? What types of things do they do? I always ask people, what do you do for fun? Or what do you do? What makes you happy? And then who is your circle of people? Because you want to know what their how their skills are working for them. You want to know who's a part of their circle, who can help this person if, you know, you have to put a plan together. And then you're asking about employment. Of course, we're looking at strengths and weaknesses, identifying the strengths and weaknesses. How are they motivated? Are they motivated for therapy? How insightful are these clients? You can tell if a client's been going to therapy because they'll use jargon. They'll tell you what their mental health diagnoses are. They're very verbal with you. If you can tell if they didn't really understand what was going on in their therapeutic process as well. My more workforce suggestions, to rule out other diagnoses. So that's your provisionals. You're looking at what you think it is and what it's not, or what it could be, right? Because you're also gathering a list of specificities. And I know that's a big word to say. We're specifically looking for what has caused this problem. What is the root of the problem, and how it's connected to other things, and how those other things are connected to it. So we're looking at their environment, anything that's exacerbated that. So this is what we're talking about when we're looking at their environment, their housing, their social environment, any issues with accessing services, problems with interacting with the mental health and legal system. They don't understand it. They have a wrong understanding of what's going on. It's causing them to be angry. The court sent you to them because they have an anger problem. They're angry because they don't understand. They're angry because they feel like they're not being heard. And it looks like they are having a manic issue because they are totally pissed off right now. That's what I'm talking about as far as their environment. Micro looks like this is what's going on in our home. Meso says, okay, well, this is what's going on in our court system, and this is why I don't understand it, and this is why I'm angry. So you have to look at all those things. Pay attention to what their culture is, because there's some cultures that are very subservient to the authority figure, and they won't say anything. There are other cultures that are very vocal, but it looks like they're being manic, or that they have an anger problem. And really, sometimes what the issue is they do not understand. So pay attention to those environmental issues that you may help de-escalate some of those issues with clients in other settings as well. And, you know, they may come to you and say, this client is totally angry. I don't understand what's wrong with her. She doesn't listen. I think she's crazy. I'm using crazy loosely because I'm a clinician and I don't like the word crazy, but this is what they'll say to you. And then you have to then take what's been given to you and then in turn look and try to figure that thing out. All right. And then there's some emerging diagnosis things that are happening in section 2. There are some assessment tools that are there for us to use. The cross-cutting symptoms of adults and children. There is a cultural psychiatric diagnosis that can be used. And they have key terms for all the culture things that you need to know, how to ask them, how to formulate them, and then you can use that tool to put into your diagnosis and treatment plans. And the alternative model to personality disorders, there are 2 models that are presented and that you can score. And basically what it says is the first model that was in the DSM-5 and that is currently in the TR, we can use it, but it does not help us talk about the person globally. And we want you to be looking at how you can talk about your clients globally and help us understand what's going on with your patient. It incorporates the use of specifiers, and it breaks down the common traits of the disorders, like a bipolar or the personality disorder, and it identifies the levels of how that person may be functioning within themselves and with the world. I know I'm cutting it, but I'm right at 12:59. Boom, I'm done. Any questions? I know there was a lot. You're on mute.
Thank you for letting me know that. Our evaluation link for today is https://www.surveymonkey.com/lowercase r/all uppercase letters, M as in Mary, G as in girl, 9, X, P as in Paul, K, T as in Tom. That is our survey link. It is password protected. The password is all capital letters, DSM5TR, just like today's topic, DSM5TR. You will get a copy of Dr. Brown's presentation if you do the evaluation and we send your certificate to you. Nurses will be posting your hours for you. Everyone who does an evaluation will receive credit and a certificate for having attended this course. The link, one more time, for those of you who need it, is https://www.surveymonkey.com/lowercase r/all uppercase letters, M as in Mary, G as in girl, 9, X, P as in Paul, K, T as in Tom, and our password is all capital letters, DSM5TR. DSM5TR is today's password. We thank you, Dr. Brown, so much for being with us. We've run over a little bit. Please join us on Monday, April 1st, when Bill Nolan returns to discuss wills and trust in a follow-up to March's presentation on probate. Thank you all for being here. Thank you so much, Dr. Brown, for being here. We love having you and love having your information. I'll be ending this presentation for us, but thank you all for being here and join us Monday.